Identification. This is when you choose to act like, emulate, become someone else. Then there is sublimation. This is redirecting unacceptable instinctual drives into personally and socially acceptable channels. So if I have intense rage, I will redirect that feeling into joining boxing or football so I can really hit some people or really get that anger out in an acceptable way. Sublimation. Regression, I think is the easiest of all, which is reverting to an older, less mature way of handling your stress or your feelings. Say you're arguing with your roommate and you stomp off to your room pouting, like, how old are you? So that will be regression. And there is suppression. This is an effort to hide and control unacceptable thoughts or feelings. Say you're attracted to someone, so you're like, I really don't like them. So you're trying to hide those feelings. Know your defense mechanisms. There's a handout I usually have Pam post. I'm going to ensure that she has put it up there. It'll give you descriptions and examples. They will come up later on. It's important to know them.
Sorry, did you say there was going to be a handout?
Yes, I did.
Okay, thank you.
You're welcome. So it takes us back to different mental health practice settings. And this is why I mentioned that no matter where you are, you will encounter mental health issues or mental health patients. It could be in the acute care setting, where this patient is a danger to themselves, others, unable to meet their basic needs, such as food, shelter, housing, or they have a dangerous decline in their mental status, or have a medical and mental health needs, so they need to be in the acute care setting. It could be also in the community health setting, which is where I work. I work in a community health center, where different levels of protection or prevention are used, primary, secondary, tertiary. You could also encounter mental health patients in partial hospitalization programs. Does anyone have any idea what those are? Have you ever been exposed to those? So sometimes after the patient is in the acute care setting and they spend, it is outpatient treatment that is offered at the hospital. So say they have done their inpatient stay, it wouldn't be good practice to say it's a psych stay. This patient is inpatient, they're getting someone administer their meds, they're getting someone who comes around and checks on them frequently, provides their meals, they have someone who come around, they have group therapy scheduled throughout their stay, and then it comes to the end of their stay and you go to discharge them and they're like, see you, you're on your way now. So that's not good practice. You want some kind of continuity of care. So very often that patient will be engaged in a partial hospitalization program, or sometimes it's called IOP, an intensive outpatient program, where it's provided through the hospital, but the patient is residing outside and they come in for services. And it's usually time limited, and after that, then they set them up with an additional outside provider to continue those services. So continuity of care is very, very important in the mental health field, because these are patients who do not necessarily seek out care or work at continuing their own care. So you have to be like advocates for them, like pushing them in the right direction. There is also an ACT team, the Assertive Community Treatment Team. The ACT team, like where I work, there's an ACT team. Several of my patients have ACT team services. And what this team does, it goes into the community. It helps them with like basic functions. It will take them grocery shopping, take them to their appointments, help them with organizing their homes, guide them through preparing meals. So the ACT team will help them to function best in the community health setting. Very often without the ACT team, these patients will not be able to live independently in a community. There are community mental health centers, which is where I work. There are rehab programs. There's even home care. So how do we treat mental health problems? Medication is one option, and that's what I try to educate my patients, that medication is only one of the many options. Therapy, talk therapy, is another of the many options. So now we're going to look at the non-pharmacological therapies. Someone mentioned CBT, and we will talk about that a little bit more forward. So therapy, a lot of patients are resistant to therapy. It's time consuming. You usually have to go every week, or usually at minimum every 2 weeks, you'll have them going to therapy. So it's lengthy, they have to commit to it. But it seeks to resolve internal conflicts. Very often the patients get to examine themselves, like going back to childhood, see what happened where, what could have ingrained these feelings or thoughts, explore precipitating factors to their anxiety, their depression. They get tools. They learn tools, and these tools are very often coping mechanisms where they can use these tools to work through, I'm getting anxious. When I start feeling anxious, these are usually my triggers, or this is what happens when I can feel myself ramping up. And in an effort to avoid a full-blown anxiety attack or a panic attack or full-blown anxiety or depression, I need to start doing these activities. Or when I do these activities, it relieves my anxiety, relieves my depression, brings me back to baseline. So patients learn tools from therapy. Sometimes they do a little bit of free association where the therapist will throw different things out. They find words that associate. So those are different therapy modalities which we won't go into specifically. They analyze your dreams. They examine transference, countertransference issues. That happens very often. When patients come to see me, they're having issues with anxiety. They're having issues with depression. Well, the agency I work for, their philosophy is that patients must be engaged in therapy to get med management services. And that is a common philosophy of many places, because meds alone do not actively treat the patient or treat the problem. The patient needs to, they need the tools, they need to explore what is the thought process that's going on that's leading to these feelings. So that's why therapy is important. So therapy could be psychotherapy, which is more verbal. It could be psychodynamic, where they look at the present state of the patient. It could be interpersonal psychotherapy, which addresses specific problems. Maybe this person has a difficult time in their interpersonal relationships, not getting along with others, not getting along with their husband. It could be interpersonal based. Or it could be cognitive therapy, where you look at, someone mentioned CBT, which is cognitive behavioral therapy. They could look at cognitive therapy, which seeks to examine the patient's thoughts, their behaviors that lead to depression or anxiety or eating. Are you feeling anxious? Is this why you eat? Because you're feeling anxious? So they seek to get into the thoughts that feed into the behaviors and help to restructure their thoughts and thereby correcting the behaviors. Very often, parents will bring children to see me and they want this magic pill. So little Johnny is not doing what he needs to do. Little Johnny is having temper tantrums. He's throwing a fit at school, breaking stuff at home. And mom wants me to give little Johnny a pill. And I'd be like, no. Is little Johnny seeing a therapist? No. Then that's where you need to start. And I'll give her resources to find a therapist. And I said, if after meeting with the therapist and after with the therapist's recommendation, we think medication needs to be added to his treatment, then we can consider that then. But it is definitely not the first line treatment. Patients should begin with therapy services, unless it's something like very debilitating that you need to get them in a better place to be able to engage in therapy. But otherwise, therapy is first line treatment. So I mentioned cognitive behavioral therapy, the CBT. Look at cognitive distortions and behavior approaches. And then there is DBT. A lot of patients report efficacy with DBT. It is very time consuming. It takes a lot of dedication to engage in DBT. But I can tell you, of all the patients that have gone through a dialectic behavioral therapy session, have come out on top. They can tell you they learn tools that will be with them for the rest of their life, tools that will guide them through life. Has anyone ever had an experience or worked anywhere where these therapies were done?
Can you hear me?
Yes.
I have a background in psychology. I have a bachelor's degree, so I have familiarity there.
Right. Was that Joel again?
Yes.
Sorry, I only know it was you because the mic is messed up.
Sorry.
That's okay. I didn't hear what you said though. So if you don't mind typing, I would appreciate it. Okay. So you have exposure to that, those different therapy modalities. And they work. So breathing techniques would be a coping skill.
I have a question.
Yeah.
Hi, this is Disha. So with these types of group therapy sessions or settings rather, are those the same as like a psychosocial group meeting or like would that qualify for group therapy? You know, because I like where I work, they call it psychosocial groups and it's like peer led. So would that be like an example of group setting as you have on the slide?
Like a CBT.
Yeah, so it's not like led by a mental health clinician or anything like that. It's peer led. So I'm just trying to get a visual of what would that look like? Is it professionally led or is it peer led? Does that change whether it's clinically defined as group?
Are you asking about the CBT or the one that's peer led?
Well, I'm asking about the just trying to make a differentiation based on the slide and just kind of defining it from what I've seen and what your what the definitions are on the slide. So I recognize that some of these are group settings.
So the CBT, DBT is usually done in a group setting. It's usually done by not just a therapist, but someone who has been trained to perform these groups because there are specific skills that you need, especially with DBT, specific skills that you need to engage the patients in and to teach them in order to, it's not just let's talk about what's going on. It's not talk therapy. It has a whole manual and tools they have to learn and things you have to go through. So those are a form of group therapy. There can be group therapy that's peer-led, as if you look at the next slide, a collection of individuals with shared interests, values, norms, or purpose. So it can also be peer-led, and while it's not moderated by a professional, they're still functioning in a group setting when they're learning from each other, sharing stories, getting insight into what's going on, and gaining from this engagement. So it can be a group therapy session that's led by a peer. Does that answer your question?
Yeah, that does.
Okay, thank you. So, yes, there are various types of therapists. If someone tells you to go to therapy, it's not just let me find a therapist. And this is why I try to explain. Sometimes they're like, I did therapy all my life and it didn't do diddly squat for me. Okay, maybe you weren't doing the right type of therapy. Or a parent will say, I'm not putting little Johnny in therapy because he won't know what to do in therapy. He can sit there and talk to someone. And I'll be like, well, maybe he needs to find someone who specializes in behavioral or play therapy. You want someone who's going to get on the floor, lay on their back, build Legos with them, and talk to them. And the child probably wouldn't even recognize that they're in therapy because they think it's a play session. So there are several different forms of therapy, and depending on what your problem is it trauma? Is it an eating disorder? There are different therapies that are geared towards different problems. So taking us back to group therapy, they function to teach social norms. Members often find it very supportive because sometimes they realize, hey, I'm not the only one. Like where I work, there's a depression group, there's an anxiety group, there's a Hispanic women's group, there's a older women's group. There's so many different groups. And by engaging in these groups, they kind of realize that I'm not alone. They get support from members. Very often they form friendships. They exchange numbers. That's an additional support person. If they're struggling outside of the group, they can call or reach out to. And they learn, they educate themselves. So it could be self-help, teaching, task-oriented education. So lots of different groups, as Mark mentioned, or different therapists, rather. Very often, too, especially as it relates to adolescent patients, will come to me and they are saying that they're having issues at home, issues with their children, and I would recommend that the child does therapy. Very often that therapist will tell the patient or share with mom or dad or whoever the guardian is that at some point during this child's treatment, I want to bring you in, because very often you need to address the bigger issue. Sometimes that therapist functions as a moderator where the child can share his or her feelings, the parents can share his or her feelings, and there's a neutral party there to moderate the conversation. So therapy is one non-pharmacological treatment. Then we also have others such as brain stimulation therapies, ECT. ECT is still done, even though it's an old method, it's still done. It is reserved for patients with major depressive disorders, schizophrenia disorders that typically don't respond to traditional treatment, which means therapy or medication just doesn't seem to be working, so you try the non-pharmacological methods. It is very important, and you should know that you need to get the patient's informed consent prior to doing this procedure. And you're probably like, duh, like, we're going to shock their brain. Why would we not get their consent? But I'm just saying it's something that it's very important that informed consent. So make sure you explain to the patient what is going to happen and make sure you get their consent before this is done. Major side effects, main side effects from this is confusion. You can have a slight headache or problems with short-term memory. And I have some patients that have done ECT in the past, and they'll tell me I've never been the same since I did ECT, or you have some patients that tell me it was the best thing that could have happened to me. So the reviews are mixed, but it is still being done. There could be a transcranial magnetic stimulation, TMS, often used for major depressive disorder not responding to medication. So this is not for the patient who's walking in off the street depressed and you're like, hey, let me send you to get an ECT or TMS done. Usually you try least invasive methods first, like medication and therapists. There is the VNS, which is also used for major depressive disorders resistant to ECT. So they did the ECT and that still didn't work. So now they use the vagus nerve stimulation methods to meet their needs. So there are some patients, you mentioned ECT and they like fly off the chair, run out the room, never gonna happen. And there are some patients who are open to trying these non-pharmacological therapies, which they've been around for a long time because they do work. It's an electrical stimulation to the vagus nerve to the brain to increase the flow of neurotransmitters. If it's custodial, then it would be the parent. Of course, I would hate to think they would haul a child off to doing this. A child, it's early years. I don't see a child being referred to ECT TMS. I don't see that happening. But say it's an adult who has a custodial. Is this person not capable of making decisions on their own? Has someone been appointed guardian or able to make decisions? Then that will be the person who makes the decisions, an adult. If someone has been legally appointed as their decision maker. It could be their conservator of health, so that person would make that decision. But still, I would hope that that they would get some buy-in from the patient before something like this is done. I feel like we're flying through the material because you guys are so quiet on the other end. It's definitely not like being in the classroom.
Listening to you.
That's good.
Hey Zoe, I have a question.
Yes.
Can you hear me?
Yes.
Okay. Because my connection's pretty bad, but when we were in class with Pam, she would post the PowerPoints with her additional notes after class.
Joel, I'm not hearing you. I heard when you said, "Are you hearing me?" That I heard clearly. I know it must be frustrating. Want to try once more?
I think she was going to ask if you're going to post PowerPoints with notes on them after class.
No, I don't typically do that.
Okay, thank you.
So we'll just have the recording from the session.
Yes, you will have the recording.
Excellent. Thank you.
You're welcome. And when you say with notes on them, the PowerPoints you have do not have notes on them?
Well, they don't have instructor notes. What Pam was doing was she was sending PowerPoints with instructor notes. This way we are actually getting a breakdown of everything, an outline of everything that we discussed during class.
Okay, so I have two different PowerPoints because last semester they conducted the online portion a lot different than it is being conducted now, and I'll have to ask Pam which one she posted for you guys.
It would be great. It was really helpful to use Pam's notes for the exam.
Okay, so I'll check with Pam because the one I did last semester, we didn't do it in this setting. It wasn't an entire day, so pretty much everything was on there, and then you guys would just check in with me. That's how we did it. So I will check with Pam to see which one she posted.
Thank you.
But it helps you guys, I don't object to doing so. Okay, on to after class. Yes. Because I'm being mentored by Pam, and she's like, don't give it to them. They'll tell you that there was no point coming to class because everything was on the slide. But I will check with her to see which one she posted, and
I was gonna say we're still here.
I'm sorry?
I said we're still here.
Okay. Now,
We're in class. We're here. We're here and listening to you.
so stress management. Who has had stress?
Yes.
Everyone goes through stress at some point in their life. But as we go through this module, you will come to realize that it's one's ability to cope effectively with stress that determines whether they end up with anxiety or end up with depression or go about life like that's in the past. So some stressors provide interest and purpose to life. Too much stress or stressors can cause distress, even anxiety or anger. Like when I was a student, well, I'm still a student, but when I was in undergrad and I was preparing for an exam, I can tell you how stressed I get. I still get very stressed. I don't sleep, I don't eat, I become restless. But then I have to hone my coping skills and use my coping skills to work through my stress. Stress management is your ability to respond appropriately and cope with your stressor. There are different factors that affect how you deal with a stressor. Your age. When I was in elementary school and I had an exam the next day, I'd probably be crying that I'm not ready. I probably wouldn't use coping skills because I didn't know how to use coping skills then. So my age played a factor. Say it's the stressor of losing a job. If you're a teenager living in your parents' home and you got fired from your job, it's, oh, well, I'll look another one. Versus you're a single parent at home with kids and you lost your job. Your response will be a lot different. Would you agree? Gender also plays a factor in one's response to stress. I would be stressed. I pick up the phone and I call my sister and I'm talking about that stressor all day long. While on the flip side, my brother might be stressed and I wouldn't hear a word about it. Because they like to say women like to talk. And we do like to talk. And that's why sometimes we probably are afflicted with lesser symptoms or it's not as pronounced because we can talk about our feelings or talk about what's presented. And there is where gender plays a huge factor. It could be culture. Yes, society kind of gives them, oh, you got to be macho, work through these feelings. No, it's okay to cry. It's okay to reach out to someone and talk about your problems. It could be cultural. I recently had an intake with a young Asian, he's 18, young Asian male, and he is having difficulties with new onset OCD. And he's not supported at all by his family. His parents will not attend appointments. They will not okay medications because, exactly, pretty typical, because where they're from, you have to dig deep within, find the strength, and work through whatever you're being afflicted with. So one's response to a stress could also be cultural. Is that Chow? Can you give us some more insight into how mental illness is viewed in that culture? It isn't viewed. There is no such thing, right? You're going to get over it. And having worked in mental health, schizophrenia, bipolar, depression, anxiety, it doesn't discriminate. So what if you're from a culture where it is not recognized? And it's not just Asians who have that view. I'm Jamaican and I'm from a culture where I remember growing up where we used to call them madmen, but they were insane people, more than likely suffering from serious mental illnesses, who were walking the street. There was no mental health care. You'd probably hear about somebody going off their rockers, or there would be some talk of some witchcraft, why someone is walking the streets or talking to themselves. There was no way of addressing mental health. And now I look back on my childhood, I'm like, oh my goodness. And I'm thinking that's my past. But for the not so upper class in my home country, it is still a reality. Mostly, no, there is no mental health. There is no psych nurse practitioner. There is no psychiatrist. There is no mental health care. There is one mental health institution, which I know its name is called Bellevue. You'll hear sometimes they'll round up the people off the street that are walking around totally insane and throw them all there. And that's your view of mental health. There's no
In New York, Bellevue Hospital in New York.
Oh, there's one in New York too? No, I'm talking Bellevue Hospital in Jamaica. There is no talk of anxiety. Like I'll talk to my sisters now that we're older, and she's like, I've always like before my test, I'll get sweaty and shaky, and I'm like, if you were raised in America, you'd have been on some meds probably. It could be religious factors that play into it, where if you pray, that'll go away. So there are lots and lots of different things that play into one's response to a stressor. It could be their life experience. It wasn't the thing in your family. So lots of different people have different views about mental health and mental health care. I'm West Indian, and so am I. There is no talk, and it's funny because I have West Indian patients. There are very few, but I do have a few West Indian patients. And I remember one patient in particular. She goes, Zoe, can I bring my mom to my next appointment, so you can tell her that I am depressed, or you can tell her that what I'm going through is real? Because maybe you're Jamaican, she's Jamaican. If you talk to her, she'll get to understand it, because her mom does not understand at all that she's suffering from depression. Her mom is telling her, get over it, pull your socks up, get out of the bed because nothing is wrong with you. And it is a cultural, just pray. Or mom brought her name to the church and everybody at church is going to pray for her. Like you're saying, and you're supposed to get better because it's not recognized. But mental illness is real. There was a lot of mental illness going around when I was growing up, just that I thought those people were mad. Or smoke some bad weed. Or it was Abia, which is witchcraft. Only to realize that it is a mental health problem. So when you're assessing one's ability with stress, you want to look at their protective factors. So if someone has a stressor, you want to ask them, what are those things in your life that when you think about those things, it makes you look forward to living, look forward to getting up every day? You want to find out, what does this person have to live for? What are some examples of protective factors you think you may hear from patients?
The children?
My children. Relationships. A big one too is spirituality. I hear that a lot from Catholics. Yes, it could be viewed as, like I said, like a possession. Like I also mentioned that I hear a lot from my Catholic patients that, oh no, I never kill myself, or I have to work this, I'll go to hell, like something like that. So it could be a protective factor, could be their spirituality. It could be their drive to succeed. They're like, no, I want to become somebody. So look at what their protective factors are. Or it could be, I have nothing to live for. What's the point? So if a patient has zero protective factors, if they have zero things in their life that makes them want to succeed, that's an area of concern. You want to look at their physical health. Does this person have, as I alluded to prior, serious medical health issues? Stage 4 cancer, end stage of some disease, HIV, which is pretty common. I have one depressed patient right now. She's a young girl, I'm going to say late 20s, who has HIV. And she is majorly depressed. And she is drinking herself in a hole. And when you talk about dealing with her depressive symptoms and taking her medication, she's like, there's no point. She's not taking her medications for HIV illness either because she has lost hope. And she's afflicted with many other medical health problems because she's not taking the medications, she's drinking on end. So you want to look if they have any physical health issues that play into their ability to work through their stress. Look at the patient's sense of self. Do they have any self-worth? Is this the patient that feels like they have accomplished anything in life? Is this the patient that feels like they have the ability to accomplish anything in life? Do they think they're important to anyone or have any value? You mentioned religion, optimism. Can they future plan? Where do they see themselves in a month, in a year? Are they vested in their care? What is their interest? What are their interpersonal relationships? Because that can play a factor. Is this a wife that is very depressed and she's arguing with her husband and her children all the time? That's going to add to her stressor. Is it someone without any social supports? They say they have no one they can talk to. They say they have no one in their corner. So those are all things you want to explore when you're assessing one's ability to deal with stress. So none of us can escape stress. Stress is a normal part of life. But again, your ability to work through your stress effectively is very important. So there can be different kinds of stress. It can be acute, such as, well, I know you'd probably say nursing school has been a prolonged stressor. And having gone through it myself, I can say I agree. But the fact that I made it to the end, what is it, 4 or 5 semesters later? It proves to your ability to effectively work through your stressor. So it could be fight or flight, where you have apprehension, you have some uneasiness, your appetite increased, you have increased respiration rate, heartbeat. Like I was always the last person in the room for every exam. Before every exam, I used the bathroom several times. I had that increased metabolism. And that was me. And that's, did I allow it to take over me where I got into the exam and I couldn't think? No. I'd use the bathroom as much as I needed to. But then I'll get there and I'll sit and I'll breathe. I'll do some deep breathing. And I'd pray. That was my coping mechanism. And then I'd attack the problem, which is the test. I get test anxiety every single time. That's why every time I went back to school for nursing, I'm signing up to start a new journey, I would be already thinking about having to do a board at the end. But you work to effectively manage your stress along the way, and you can get through your stressor. Some stress could be prolonged. It can be chronic anxiety or chronic panic attacks, which a lot of patients do have. They could have issues with sleep from the prolonged stress. They could have depression or even chronic pain. Sometimes mental health problems can even present themselves into somatic symptoms. They can be having pain or stomach aches or some somatic symptom from the depressive state. They can have weight increase or decrease. Some patients that are stressed will tell you, I stress eat, or I don't eat when I'm stressed. So weight increase or decrease. It can cause an increased risk for stroke, heart attacks, or for control of their medical health problems. And this is why stress management is very, very important. Yes, it definitely affects your immune system. When you're stressed, All of a sudden you feel like you're coming down with a cold, your body feels a little bit weaker. I get a headache sometimes if I'm stressed out. So it definitely affects your body. And this is why stress management techniques are very, very important. Not just for the patient who has a mental health issue, but for everyone. Next thing you know, your blood pressure is sky high. You can't concentrate. You become irritable. And it increases your risk of other illnesses. So if you find yourself stressed, if you know anyone that's stressed, you encounter patients that are stressed, engaging them in activities too, or having them like therapy, or helping them to work through designing coping skills to help them work through the stressors are very, very important. So how do you treat stress? How do you manage stress? Therapy, such as CBT, which does the cognitive reframing and restructuring of irrational thoughts. You can teach them relaxation techniques, such as guided imagery, breathing exercises, muscle relaxation, physical exercise. Even sometimes I feel myself getting overwhelmed and doing so much, and I stop and I just breathe. Just take a few minutes to breathe. You'll see how quickly you can ground yourself. Journaling is a coping mechanism a lot of patients share with me that they use. They write their feelings out. Journaling is not for me. I've never journaled. I don't think I'll ever journal. But for some people, it works wonderfully to be able to write out their feelings. It works for them. Mindfulness, diet, exercise. That works for. Which one works? Journaling? Yes, journaling works for you. Diet and exercise. And this is why when patients come in stressed and anxious, I'm like, let's talk about your lifestyle. Healthy eating, exercising. It's not just, oh, the pill's not working, so you need to change my pills, you need to up my dosage. Let's talk about healthy lifestyles. Get enough sleep, eat healthy, exercise. Try to engage in fun activities. That's how you're going to manage stress. Because if you don't manage your stress effectively, then that is what develops into anxiety, it develops into depression. So we're going to look at some important concepts and definitions. Therapeutic communication. That's a thoughtful sending and receiving and interpreting of messages. It's not just simple conversation. So when you seek to engage with a patient, it's not just, hey, how are you doing? Let's talk about what's going on. You're mindful of your choice of words. You're mindful of your body language, your eye contact, or your lack of eye contact. If the patient is irritable and agitated, you're not going to go there and hold a stare. So therapeutic communication is being mindful of all those different facets of communication, making sure you're communicating effectively. When you engage in a relationship with a patient, you want to make sure it's a therapeutic one. Make sure the client is the focus and that you're focusing on their needs. You want to make sure you have goals set. You want to make sure whatever treatment you're using is theory-based. That means it's been tried and true. It's been implemented because you have these expected outcomes. You want to be very objective, and you also want to be open to supervision. And open to supervision means open to discussing your feelings and thoughts as it relates to caring for this patient, working with this patient. If you find that you're spending more than half your shift with this patient, the supervisor will say, hey, what's going on here? Let's talk about how you're managing your time. So you want to make sure you're open to supervision. Even in my job, I do supervision twice monthly. I meet with the resident psychiatrist and I talk about patients that I am struggling to connect with, and then we can look if it's any transference, counter-transference issue. I talk about how I am as a person, how I'm managing my health, my own mental health issues. So supervision is very important sometimes in the field of work. In nursing interventions, even though you're not writing care plans anymore, as I come to understand, nursing interventions still hold a lot of importance. You want to establish, maintain your therapeutic relationships with your patients. Be self-aware, be aware of your own feelings and thoughts. Are you working with a patient who is suicidal? Have you had a history of suicidal behaviors or thoughts? Did you just lose a loved one to suicide? So self-awareness is very important because that will impact your ability to establish therapeutic relationships with patients. You want to identify patients' behaviors. Safety, always paramount. You want to modify the environment as needed. Is this patient telling you that they're suicidal, they're having thoughts of hurting themselves? You're going to go in there to do a dressing change, leave your scissors out on the night table or leave your scissors out on their bed. You just want to make sure you're ensuring safety. Give medications as prescribed. You also want to watch for the effects of those medications you give to see if they're achieving their therapeutic goal. So you can then reach back out to the provider and say, hey, I noticed when I gave him the anxiolytic, he calmed down in a few minutes. Or when Mr. Jones has his anxiety attacks and I give the pill, it's not working. So you want to be able to advocate for your patients. You want to engage them in activities that's tolerated. So not because it's movie time on the unit and everybody needs to come to nurse's station to watch a movie and Mr. Jones decides he wants to lay in bed means Mr. Jones has to come up there. If he's in a severely depressed state, do you think he wants to engage in a communal activity? No, he wants to isolate. He wants to stay in his room. So while you want to engage it, it should be as he will tolerate it. Avoid confrontation. Patient is having an hallucination. You will not confront them. No, I don't see anybody on that wall over there. So there's a much more therapeutic way to express your thoughts with the patient. So avoid confrontation. Be respectful. Confidentiality is key. So even though you're working on the unit and you saw this adolescent from your daughter's high school come in and you heard that she's there because she was molested by her older brother and now she's suicidal, no, you cannot leave the unit and go share that with anyone else. Confidentiality is key. You want to make sure you're adhering to HIPAA laws, not walking away from computers, only sharing information with those that absolutely need to know information about the patient. You want to be aware of your federal and state laws in each facility. I'm sure when you get hired and you go to be onboarded, you'll be inundated with tons of information and it'll probably be overwhelming at first, but as you get your feet wet, get used to your environment, take some time to familiarize yourself with different rules and laws of each facility. I mentioned share clients' information only on a need-to-know basis, and you need the patient's consent to share information for those not directly involved in the patient's treatment. I can't tell you how many phone calls I get from girlfriends, from wives, from husbands who call my office wanting to know what Mr. Jones talked about because she noticed that he hasn't been the same since it. Or sometimes they call to share information. And that information sometimes is good. It's considered collateral data, but I only listen, I only take the information, I do not share what the patient has discussed without the patient's permission. Sometimes I'll have, especially my young adults, especially when they have their psychotic break, the patients the parents often step in and assume responsibility for the patient's care, but this patient is still an adult, and they'll be like, I need to know what made these, I need to know this, I need to know that, and I'll be like, I don't see a release of information. And they're like, what do you mean? I'm his mother. And I'm like, no, he's an adult. He needs to sign a release saying it's okay for me to discuss these issues with you. And same, you could be on the floor caring for the patient. Someone comes in and is asking you all these questions. You need to ask yourself, do I have the patient's consent to share this information with this individual? Even though it's their wife, their husband, their child, you need to ensure you have that consent in place. And As a nurse, you should always take steps to avoid any violation of your patient's rights. You're going to make sure you help your patients recognize and explore their thoughts and feelings, and that goes back in our assessment phase. You're going to help guide them towards insights, as in, I noticed that you mentioned every time you go to work, you feel anxious. Maybe there's something at work that's causing anxiety. So help them to work through what they're talking to you about. You're going to teach and validate positive coping skills and behaviors. That's where you come in. So they share with you that they do deep breathing, they drink alcohol, they read. Oh, you have two very positive coping skills there. You're reading and you're deep breathing. But did you know when you drink alcohol, it further causes depressive feelings? So you want to educate them. You want to help them to identify their support systems. Sometimes patients will tell you, oh, it's me and my lonesome self. I have nobody in my life. There's nobody for me to reach out to. When in fact, this patient has a therapist, or the patient lives at home with parents, they have a spouse, you can give them suicide hotline numbers, you can give them numbers to crisis teams they can reach out to. You want to help them to identify their support system so they know that they are not alone. As a nurse, you're going to monitor their physical needs. Are they hydrated? Are they eating? You're also going to monitor the changes in their mental status. Maybe this is a patient that's been on the floor for a few days. When he came in a few days ago, he was upbeat and cheery, and you notice he's laying in bed, probably catatonic, not moving, very rigid. So you want to make sure you're also paying attention to the patient's medical needs as well. You're going to educate the patient and their family about the patient's mental health condition. Is it something short-lived? Did they just get a diagnosis of like a bipolar or a schizophrenic disorder? Is it something chronic? Is it something where they're probably going to need to take medications for the rest of their life or for a very long time? Is this something where they can just take medications as they need it? So you want to make sure you educate them. You want to educate them about the importance of complying with treatment. So on discharge, we recommend that you follow up with an outpatient therapist, an outpatient prescriber, and you want to teach them about the importance of doing this because they're in the hospital for a few days. I'm assuming it's a hospital setting, and they start feeling better. Why? Because they had all these added supports given to them. They've been taking the medications while they're there, and you discharge them with a 30-day supply, and they think, voila, I'm better. I don't need to follow up with anybody, but you want to teach them the target symptoms of the medications, and if they stop taking them, then they can probably have a decline. So education is very, very important. As usual, respect is of utmost importance. Be respectful in working through patients with their feelings and their thoughts. Remember, you work as a member of a team. As I mentioned, with like my patients going patient, and sometimes, very often actually, there's no follow through with reaching out to their outside providers. Then often there isn't continuity of care, and then the patients often fall to the wayside. Remember, the diagnosis is with the patient first. So you don't refer to the patient as the schizophrenic in room 4 or the bipolar patient. You look at the patient as an individual and how they present. Look at them as a person. Always keep your sense of humor and a balance with that, because sometimes you just have to make light of a situation, learn not how to take things personally, especially working with mental health patients, because they can say the darnest things. I can't tell you how many names have been called. If you're thinking it, yes, I've been called it. You just have to find humor in it, or a good balance of such where you can able to appreciate the patient as being afflicted with a mental health condition, and these are symptoms of the illness. Again, get supervision for your questions, any problems you have, whether to validate your own feelings or to work through difficult situations. And that is the end of the first half. Any questions? You guys fall asleep?
No, no question.
It sounds like you, I assume, you have a good understanding of everything so far.
A pretty good idea.
Okay.
I have a quick question. I don't want to jump the gun, but is there going to be content on like safety as far as like patient interactions? If patients are, some mental health patients get violent, is there content on that, or is I guess it's a good place to ask it.
Who's talking?
Bisha.
Bisha?
Yeah.
Can you give me a little bit more, like exactly what it is as it relates to safety?
So I guess I'm just thinking of like patients that can potentially become physically violent or aggressive towards the nurse or any other staff in various settings, and I guess further to that question, if patients are I guess verbally aggressive and in a threatening kind of a situation, how would we handle that? I don't know if that's coming up or if this is a good place to ask.
So where we work, there will be protocols in place, as in how do you deal with violence, or how do you do it with patients who become like hands-on or such. But I can tell you, say patients who are like hurling expletives or the verbal abuse, trying to address it in the moment is probably not the right time. Like, I can't tell you how many patients have, for lack of a better term, cussed me out in their appointments. And it's very often around substances that they want me to prescribe that I will not prescribe because it's not in their best interest, or they have a history of drug use and now they want me to prescribe a drug that has a potential of abuse. And usually you let them have their say, and I will, like in my setting, I will have the office manager sometimes address it, or sometimes if it is that they have their say and then they leave, the next appointment when they're in a calmer state, I'll address it. As it relates to hands-on, if you're working in a hospitalized setting, I'm sure there are people there to support you. So if you are, first of all, if you're approaching a patient who is irritable, angry, manic, with potential of causing harm, I would implore that you don't do so alone, that you make sure that you have supports with you when you engage with this patient. So should this patient become violent, make sure you position yourself, like even something as simple as my office setup. I position my office where if I have to leave my office, I can get to the door first. Because I am locked in a room with someone who, sometimes they do become very loud and boisterous. I've had one patient slap my vase off my desk and smash it against the wall, overturn a chair, break my table. And that's because I said, I do not feel comfortable prescribing a benzo for you. So it could be different things that sets the patient off. Just safety is key, not just for yourself, but also for the patient. So make sure you have other supports with you. And again, wherever you work, there will be, like, whether you call code a code if the patient is out of control. Does it answer your question, Daisha?
Yes, thank you. I was just recalling a time when I was new to this facility. It was a methadone clinic, and we had patients come there all the time saying, "Oh, I will kill you." And I was not there in a counseling role, but I would hear that all the time, and it was just, I don't know, I didn't really get the sense that there was a lot of urgency around comments like that, and I'm thinking, this is very serious. I wonder, the nurses that were there were in a completely different setting and, had different barriers, physical barriers that would, between them and the patient. But I would hear the patient say that to counselors all the time. And I'm like, how come this isn't handled in a very specific way? So I was just recalling situations like that, thinking, okay, how would I handle this differently, being that, we're preparing for nursing.
Okay, so say a patient comes in my office and say, I will kill you. Is this patient in a manic state? Is this patient just upset? Is this the first time this is occurring? So I'd probably call crisis. Or some people would say if they feel threatened enough, they will call the police. Like that day when the patient totally trashed my office, the police was called. It's destruction of property. The police was called that day. It wasn't my doing. The office called the police. So you can get legal involvement as necessary. I was taught to never face your back to the person and be aware of the items that can be used as weapons. Yes. So you can have ways to call for help, like if you're working, and avoid stuff that can be used as weapons. So make sure, like, whatever's in the room, what's around you, you don't have stuff there that they can grab and use to hurt you. But I must say, that day, I got my office totally trashed. I was able to sit there and look at the mayhem around me. I guess you get immune to it after working in it. And like you say, Daisha, you were there not like a regular staff. So the staff is probably used to Mr. Jones mouthing off all the time. So he probably got a few warnings. He probably had someone reach out to him, talk to him. If you continue with this behavior, we cannot no longer service you here. So it's probably something they were more used to.
Thank you.
Not that it makes it appropriate at all.
Mm-hmm.
Mental health issues of children and adolescents. Eating disorders. So a disorder exists when behaviors are not age or culturally appropriate, and they result in maladaptive functioning. So that's when it's usually termed as a disorder. One of my biggest passions is working with children. I was a school nurse for 10 years. In Jamaica, I worked as a teacher. I love children. Now I see children probably 50% as much as I see adults. And then I remember when I was in school, a lot of my classmates were like, I don't know how you're choosing to treat kids. I couldn't treat kids. I can tell you, they are not little adults. They come with their own issues, but it's like having two patients. You treat the patient, and then you have to deal with the parents. It can be a lot more than just working with an adult, but it's my passion. It's something I like doing. Intellectual deficit disability. This is a deficit in intellectual functioning, reasoning, judgment, academic learning, learning from experience. So very often, like when I'm doing my intake, I will ask if this child has ever been diagnosed with any learning, behavioral problems, anything in the past. This child will have deficits in functioning and fail to meet standards for independence or social responsibility. They'll have difficulties in functioning as it relates to their ADLs across multiple different environments, usually occurring before age 18 during the developmental period. Because if it is that this child had an intellectual disability, then it kind of gives you a little bit more insight as to when this started or what may be presenting. It could be mild, it could be moderate, severe, or profound. There is a slide here that goes through the different degrees of intellectual disability, the mild, moderate, severe, or profound, and the different IQ levels that's noted in each level. You can read that and look it over when you get a chance. So
what are the percentage? I'm sorry. What are the percentages on the side in the parentheses? What are those for?
how often that percentage is usually presented in intellectual disability. It's usually 1 to 2% of those with intellectual disability that have a profound intellectual disability.
Okay, thank you.
You're welcome. So what are the causes? It could be genetics. It could be something with the chromosomes. It could be something that occurred during prenatal care. Or it could be environmental, increased lead levels, some toxins ingested during development. So there are lots of different reasons which could account for one having an intellectual disability. Language disorders. This is a child or someone who has persistent difficulties in acquiring and using language. And it will be present in the spoken language, written, or even in signing. This child will have reduced vocabulary, have a reduced ability to construct sentences. They will have impairment in communicating socially or in general. And their abilities will be substantially below what is expected for age, usually in the early developmental years. You will see the last bullet pretty much at the end of every disorder, where it says not due to medical or neurological conditions or intellectual disability. Because if the child already has an intellectual disability, then it's understood that they would have had deficits in language. Is that understood? Or they could have had some medical or neurological condition that would have accounted for a language disorder. So if it can be attributed to a medical, neurological, or intellectual disability, then it is not a language disorder. So a language disorder is everything if it's not attributed to medical, neurological, or an intellectual disability. And I say that because as we go through the different disorders, you will see the disclaimer at the bottom if it is not related to or not a symptom of. So this is a child where, yes. So this is the child where they will probably have birth to 3 services. Like the pediatrician will probably note that something isn't quite right. Little Susie should have been saying a few words by now, or mom is saying, oh, my other kids were talking at this age. So this is the child will probably have like speech or birth to 3 services. Speech sound disorder, a phonological disorder. Persistent difficulty producing speech sounds. The disturbance limits effective communication. It interferes with academic achievement. Onset is in the early developmental period. And again, not due to congenital or any acquired conditions. It has to continue past the age of 8. So after age 8, it is understood that kids would have been at that age speaking clearly. So if it's beyond age 8 and they still have these issues, then it could be classified, if they meet all the different criteria, as a phonological disorder. So these slides are really just to give you some insight into the different things, that present.
So a quick question about that.
Yes.
So with birth to 3 or those other early intervention services, would they would be seeking to, I guess, I don't say rule out the disorder, but more so like treat it ahead of time. They would try intervention so that this would be hopefully corrected before age 8, correct?
Yes. Yes.
And so you're saying that if it's past 8 and these are still ongoing issues, then it will be, I guess, documented and diagnosed as a disorder?
As a speech sound disorder, yes, because before age 8, a lot of kids have not grasped the language very well. They could have a little bit of deficit. It's understandable at that age, but after age 8, then it becomes a disorder.
Okay.
Then we have childhood onset fluency disorder, and you must have picked it up by now. I stutter. I've stuttered my entire life. When Goodwin approached me and asked me to do this class, I was like immediately anxious. I was like, I stutter. I can't teach a class when I stutter. But then I was like, let me do this. And I just worked through my stuttering. And yes, I just stutter along like I didn't just stutter. And I just keep talking. But then for somebody else, you didn't notice. Then for somebody else, oh wow, then I must be getting better at this. For somebody else, they'll be like, they get very anxious about it. They don't engage in public speeches or engagement because they stutter. I do stutter. And my daughter sadly stutters. But I try to teach her ways just to breathe and to work through it. So stuttering, it's a disturbance in fluency and patterning of speech. There could be difficulties with sound, syllables, and repetitions. There could be sound prolongations. When I was younger, I must say I had a harder time with it, and I noticed that my daughter, she struggles with it. Like sometimes she will try to say something and she's going like, and I'm like, Zari, stop. Take a deep breath and just say it. And it works. So instead of prolonging the sound, you have to learn to just stop the thought. So it's how I have learned over time. So she's still young, she's still learning. There could be broken words. There could be audible or silent blocking. Like sometimes I would want to say something, or sometimes I'm talking to her and she's trying to get the word out, and she just can't get the word out. And I just wait until she can, or sometimes she'll become very frustrated with not being able to get the word out. There could be circumlocations, and that is the use of many words where fewer words would be used. Like if it is that I have a hard time pronouncing one word, or I know I'm going to stutter in that word, then I will choose to explain it using a sentence instead of just saying that one word that would have gotten the same thought across. So sometimes words are produced with excess tension, like you can see her, the veins in her neck standing up sometimes when she's trying to get that word out. And she has to learn her own coping mechanisms to work through the stress it brings to speak. It can cause social anxiety. That's what I experienced when I was first approached to teach this class. I'm like, oh, I don't know about this whole thing. I stutter. I can't stand up there and talk like I don't stutter. But I'm like, you know what? I can do this. I must say for her, as much as she stutters, it does not inhibit her socially at all. I must say she has a great group of friends who has never made her feel any inferior way about her stuttering, because she stutters around them and she goes about life as if everything is well. Again, it's not due to any medical or neurological condition. And that's childhood onset fluency disorder. I had a patient, had a new intake last week, and she was 19. As I am talking to her, she's having the hardest time stuttering. And I could tell it was a video call, so she starts moving the video down to her chest. She didn't want me to see her face anymore. And I had to share with her, like, this is where divulging personal information, it was safe for me to say, hey, I stutter too. She's like, you do? Then how come? And she said the same, I didn't hear it. I'm like, because maybe I'm talking to you now and I'm very mindful of slowing down my words, and I stutter too. And she felt a whole lot more comfortable, and we had our intake and she was stuttering along, and we had our intake and she wasn't any more embarrassed. I could see her face, I could see the difficulty she was having, and she felt comfortable because I shared that information with her. So that's an example of where sharing personal information can be beneficial to the patient. Then we move on to the social pragmatic or it's a communication disorder, social communication disorder. This is where the child will have persistent difficulties in social use or verbal or nonverbal communication. There'll be deficits in greeting or sharing information. There's impairment in the ability to change communication style to fit social context. So this child has a difficulty communicating socially, like using the right communication styles in the right context. They have difficulties understanding what is explicitly stated. It impacts their life and their social functions. And again, it's not due to any other disorder. Usually apparent after age 5, even into the early adolescent years. Apparent after age 5 because before age 5, it's understandable that a child would have difficulties with following conversation rules and storytelling and those things. So again, after age 5. Selective mutism. This is one I hold very near and dear to me. Only because in my 10 years of working as a school nurse, there was a little boy who was selectively mute. He started at a school in pre-K. When I left the school, he was in first grade. So that's pre-K, K, and first. And that little boy did not say a word for the entire 4 years that he was at school. We reached out to the pediatrician who penned us a nice letter to say, little Johnny is selectively mute. When little Johnny comes to his appointments and my visit, he's very inquisitive, asking about the charts on my wall, running around screaming at his sister. And we were like, what? Are you telling me this preschool up to first grade child has that much self-control where he doesn't say a word in school all day? Yes, he does. I remember one day the teacher said he had the headphones on and he was on the computer. And whatever it was very funny. And he went, huh? Everybody went. And when they went there, that he went, like, oh no, I spoke. The father showed us videos of this child screaming, yelling at his sister, being a typical child. And this is the child that has so much restraint that he is selectively mute in the educational setting. So this child has consistent failure to speak in social situations where one is expected to speak. I mean, you're at school, teachers are asking questions, he's engaging with friends, but he will not speak. Did the same. Is he talking now in school? Yes. I'm curious as to whether this young man, and I will have to reach out to someone there to see how he changed schools, to see if this young man has started talking. He can speak in other situations. It impacts his academics. Of course it does. How is a teacher going to assess his ability to read or to say sight words when he won't speak? And if it continues into adulthood, it's occupational and social situations. I have one patient that is selectively mute. And when he comes to his appointment, he sits, he brings his chair right next to mine and he takes out his pad and he will write everything he has to say. And it is yes, the social worker has looked into it. Does he not have friends? But then we have to look at when it started. It started at the beginning of preschool. He has been through 4 teachers, 4 different classrooms, 4 different social groups, and this hasn't changed. So yes, you want to look if there's something happening or did something happen to the child that is causing this selectively mute state. It can be with a precipitant or it can be without a precipitant. It can be due to a traumatic event, abuse, them being anxious. It could have precipitants, and that's why trying to go to the root of the problem is very important to see what could be causing this child to be selectively mute. This failure to speak is not due to a lack of knowledge or comfort with the language. So he knows how to speak. He speaks very well. but he's choosing not to speak. So for anyone to be diagnosed as selectively mute, they have to be selectively mute for at least 1 month. So if it lasted 3 weeks and stays, then sad enough, it's not selective mutism. So as you get into mental illnesses and we go through the different disorders, you will learn also that according to the DSM-5, which is the book, which is my Bible for psychiatry, it has all the different disorders and it tells you presented for 6 months, for more than a week. So it gives you different time limits as to how long something needs to present to be labeled as. Yes, it still counts. It definitely still counts. Then we have Rett's disorder. It is a relatively uncommon disorder. It affects both males and females. The males, if they're afflicted with such, are usually not viable at birth. Onset is usually prior to the first birthday. Usually begins at ages 5 and 30 months. So this is a child that will appear normal at birth, and as they start to develop, they will cease to gain their developmental milestones. They will lose skills that they already gained. They can have stereotypic hand movements like the hand wringing movements. They will have poor social engagement and poor coordination. Rett's disorder severely impairs this child's ability to have expressive or receptive language. Very often they'll have scoliosis, decreased eye contact, and this child usually doesn't live beyond age 40. Like in the 40s is their life expectancy. So that's Rett's disorder. There are so many disorders here. We're just going to touch on the majority of them just so you can have some insight into them. Oh, can you tell us a little bit about it, Joelle? It was very sad. So as you get out there and you find your place of work, you'll be exposed to a lot of different disorders, and we're just trying to expose you to some of them here. So when you get out there, so this is what Zoe was talking about. She was sweet but had behaviors and communication impairments. Yes. Compulsions as well. I have never personally worked with anyone with Rett's disorders, but I can assume it would be pretty interesting to learn about them. Thank you for sharing, Joelle. Then we move on to Autism Spectrum, one that's a lot more common. This is a child who has persistent deficits in social communication and interactions across multiple contexts. They'll have deficits in social and emotional reciprocity. There'll be deficits in nonverbal communication. They have deficits in developing understanding and maintaining relationships. I have a lot of adult patients who have autism. I have a few younger patients who have autism as well. They usually engage in restricted or repetitive patterns of behaviors, interests, or activities. They insist on sameness. They're usually inflexible with their routines. They can have hyper or hyporeactivity to stimuli in the environment. And there are different levels of severity. So you'll hear about someone being on the autism spectrum because there are different levels. The signs and symptoms usually begin prior to age 3. They can have a persistent pattern of inattention or hyperactivity, impulsivity, I'm not sure what PowerPoint you're referring to, Amy. Okay. Symptoms usually present before age. Oh, I'm sorry, guys. I went on to ADHD. So autism usually has different levels, and that's what you were asking, Amy. They usually have different levels where the signs and symptoms develop prior to age 3. I have a very close girlfriend who has a son with autism, and normal birth. He was normal up until he got to like age 2, and she noticed that he wasn't meeting his developmental milestones. And he started out by having normal speech. He was saying some words, and she realized he started regressing. So they had birth to 3 in the home, and he was diagnosed with autism. And he's now 4, and you've heard of the nursing diagnosis of caregiver role stress? Yes, it causes a lot of stress for the parents. He's very, very inflexible with his routines. He wants the same things the same way all the time. If she peels his banana for him and it breaks, he will not eat it. When she organizes his food on his plate, it has to be in a certain way. She has to separate everything and put them in a certain order the way he wants it, or he will not eat. And he wants the same thing to eat every day, all the time. He's getting birth to 3 services. He's getting services from home. As they age and engage in therapies, because as young as he is, he's in OT, PT therapies, he's in a lot of different therapies. They tend to, judging from my patients that I have relaxed somewhat in terms of their like flexibility with their routines and stuff. But autism spectrum, it is a lot more common, and we see it a lot more frequently. Yes, and depends on where they fall on the spectrum also. I've had autistic patients who, I have one autistic patient who's in college right now studying physics. He's as smart as ever, does fairly well, but he struggles socially, like the social aspect of it, like he doesn't engage very well. So there are lots of different levels to it and how they present. What does RBT stand for, Joelle? Okay. Several years working with kids with special needs. Okay, autism specifically. When I was a nurse in the school system I worked at, when I was an LPN before I became an RN and had my own school, I worked in the special ed room, and there was a lot of kids with autistic behaviors. It can be challenging, and it does require a special skill set to work with this population. And I'll move on to the good old ADHD, that everybody knows about because it's so common. And as people get into college, everybody wants ADHD. Why do you think? Yes, the meds. Adderall specifically, yes. ADHD is treated with a medication that's a substance of abuse, but we'll get to stimulants. ADHD is a persistent pattern of inattention or hyperactivity, impulsivity. It's more severe than the typical age and development. So, you know, kids don't sit still, you know, kids will jump around, kids won't listen, kids will lose focus and concentration. But it's that little boy or little girl you say like, something isn't quite right. That's just more than the normal amount of stuff. Symptoms usually present around age 7, can be as late as age 12 before they get diagnosed. It interferes with their function in at least 2 settings, and that's pretty important because I will have sometimes patients come in to see me and mother is telling me, oh, little Johnny's off the wall at home. He won't sit still, won't focus with his homework, won't do this, yada, yada, yada. And I'm like, can you send a release so I can talk to the teachers? The teacher's like, oh, he comes to school, he sits, he does his work, he's my model student. With ADHD? Probably something with parenting, something, maybe it's a dysfunctional home, but there's something else going on there, but this is not ADHD. Symptoms interfere with academic, social, or occupational functioning. I have adult patients with ADHD who, just like in school, they won't sit and focus. They're at work, they're jumping from one task to the other. They don't finish things effectively. They can't get things done. And that is a problem. Much like in the academic setting, they're struggling. Like this young man that I have in college, he also has ADHD and autism. And he is struggling because he's very smart where he's getting his work done, but he's struggling to focus and concentrate. But he does not like the way he feels when he takes medications for his ADHD, so he doesn't want to be medicated. There's a high incidence in families with a pre-existing diagnosis. So chances are, I'm doing too much talking here. Chances are, if mom had a diagnosis, the child will, or if the brother did, then the sister will. It's familial very often. So there are different theories as to what could have caused ADHD. There's the maternal smoking theory, there's the lead theory, there's also the dysfunctional parenting theory, or it could be environmental. I learned last week that kids that are adopted, there's one theory that they also develop ADHD. So there are lots of different theories out there as in what could have caused it. Child will present as impulsive, they'll be fidgety, they'll have difficult social relationships, and a low frustration tolerance. That means they get very frustrated with stuff very easily. So this is not the child who's gonna sit there and try to do this. Can it be diagnosed in adulthood? Aha. So very often, just over the weekend I had a patient. I've been treating her for the past year and a half. She comes to me and she says, oh, Zoe, I've been in school and it's so hard for me to focus, so hard for me to concentrate. And I've been reading about ADHD. And I think I have ADHD. So when it comes to adults, I don't discredit their reports, but this is when I require that they do a neuropsychological evaluation. So this is when I refer them to a different office that does a neuropsych testing. And I must say I referred quite a few people, and I am yet to have anyone come back with a conclusive diagnosis of ADHD. Again, I mentioned it's usually diagnosed before age 7, somewhere there, like pretty early up to age 12. So it's kind of unlikely that you hit adulthood and boom, you have ADHD. I'm not saying it can't happen, but so I don't become the gatekeeper to your diagnosis. I send you to an outside source where you get the testing and a whole battery of questions, and they go through everything with you. And then it's determined whether or not you'll, in fact, do or don't have ADHD. As I mentioned, the thing about ADHD is the psychopharmacology that goes with ADHD. ADHD is treated with a CNS stimulant, such as Ritalin, Dexedrine, Adderall, Vyvanse. So there are quite a bit of stimulants out there. College kids, people in the working world, I still have difficulties. I still have difficulty following steps in order, like 1 to 5. Are you referring to the slides or? Oh, no, ADHD. Oh. Right. So it can pose challenges in life. Like they'll have difficult time like following like multi-step directions and stuff. But why it's a red flag for me as a prescriber when a patient comes to me and now they have this new onset ADHD in adulthood, is because the drugs of abuse And the drugs also have street value. Like I have one patient right now who he's on Adderall, max dose is 40, he's on 30 in the morning, 10 at night. And he continually complains and complains that I have a hard time focusing at night, I can't focus at night. And okay, I do not want to prescribe Adderall for you to be taken at night because, why? Who can tell me? It keeps you up. It's a stimulant. So why would I prescribe a medication for you that I know should not be taken at that hour? But he insists that I'm in school, I have homework to do, and I can't focus. So I say, okay, how about I prescribe a medication that's a non-stimulant? It's still FDA approved for ADHD. It's still going to help you with your focus and concentration, but it's not a stimulant. He doesn't want that. So that's a red flag for me. Then over the summer, it was probably his third request to have an advance on his Adderall because he was going on vacation, where both myself and the pharmacist went, not at all. And that is correct. Sometimes you have people who went under the radar their entire childhood. Maybe they were never referred for testing. There's several reasons why they would not have gotten that label. And you do have adults who have ADHD. I'm not saying adults can't have ADHD or new onset, because sometimes a patient comes in there and they're all over the place, And you're like, there's some ADHD going on here. But I'm just saying we have to make sure we can tease it out effectively and appropriately. And that's why I will refer patients to neuropsych evals to get that done. So back to this guy. So every visit we have, he's asking me to increase his Adderall, increase his Adderall. So I am like, you're on the max dose of Adderall. Unless you agree to having an add-on of a non-stimulant, I can't increase it. He picks up his meds. Say he picks up his med Friday. On Monday, he calls and he goes, you know what? So he's taking the 30 milligrams and the 10 milligrams. So he just picked up how many pills? 30 days worth. That's 30 of one, 30 of the other. So he has 60 pills in his possession now. He calls Monday to say, this Adderall is not working, and switch to Vyvanse. Okay, I will allow my patient to be autonomous and I will change the script as you're requesting. So he goes, how soon can I pick up the Vyvanse? I don't think so. You just picked up 60 Adderall pills on Friday. I am not going to order another 60 of another stimulant for you on Monday. So he was very upset with me, but I did not fill the script until he was a week before he was to run out of the Adderall. Because it is a drug of abuse. There's a high street value for this drug. You also have non-stimulants, and this works wonders for those patients who come to me, usually the kids, where the parents are not quite sold on the medication therapies, are not quite sure if they want little Johnny taking a medication because it's gonna this. And I'm like, we have non-stimulant formulas such as Strattera, there's Confidentiality, there is Wellbutrin that are not stimulants, and very often parents are a lot more receptive to using the non-stimulants. Because a lot of parents are like, I don't want my child addicted to a drug. And Adderall, Ritalin, they are drugs of abuse. So make sure we don't use them as first line, and we use other medications first. We're gonna break here for a lunch break. When we come back, we will pick up where we left off. So this lunch break, I'm gonna give you it's 12. We're gonna resume at 12.